times the outcome of a war was decided by who had 3% more soldiers, got there 2% faster, 5% more fuel. These tiny, tiny margins made really significant differences in this outcome. So what they did was they hired Wald, who was the head of the statistical research group, to help them figure out armoring their planes. You have a limited amount of materials, so you need to be productive with it. Now, if you cover the planes in armor, extremely bulletproof, they're really hard to shoot down, but they're slow, they burn a lot of fuel, they can't go as far. If you leave them light, they're really fast, they can go really far, but they're very easy to shoot down. So how do we balance this strength versus speed versus fuel consumption together? The first thing Wald had them do was start gathering data. He said, I want you to map out when these planes come back, everywhere that you see bullet holes on them, and I want to start looking at that data. And they got something that looks like this. And their reaction was much like mine, was you feel like you know exactly, okay, this is silly that we hired this whole research group, we know exactly where we need to put the armor. But then Wald said something that was very surprising to them, and the first time I learned about this story was very surprising to me. He said, you're gonna put the armor where the bullet holes are not. Any place that you don't see a bullet hole is where the armor needs to go. And confused, they asked, why would we do that? And he said, you have to remember these are the planes that made it back. So this is actually a map of everywhere a plane can get shot and still safely fly and return. So my theory is that if you get shot in the places we don't see bullet holes, you don't get to fly back. And as soon as that's said out loud, it makes complete sense, right? Of course, it's so obvious, but it wasn't our initial instinct, and that's what's important. This was actually a map of this plane's resiliencies, its strengths, but our instinct was to immediately label it as the weakness and apply the intervention in the wrong spot and in the wrong way. And had we done that, not only would we have not helped, we would have actually made the situation as worse as possible. These would have been slow planes that couldn't fly far and were even easier to shoot down. And I think this serves as a really good metaphor for substance use disorders and co-occurring mental health issues. A lot of times we think we understand the issue and we apply the intervention, and because the intervention misunderstands what's actually going on underneath everything and kind of behind everything, we're actually making the situation a lot worse for individuals and people affected by substance use disorders. And the data backs that a lot of what we're doing might actually be making things worse. So when we talk about addiction, this is the American Society of Addiction Medicine. This is the definition we get, that it is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. So a lot of times people talk about those as causes, right? There's a genetic component, you have trauma, the environment you're brought up in, exposure to it. We see that these are, predispositions and risk factors, but the actual driving force is considered a brain disease. And it's really important to understand that, and that'll be my goal kind of through the neuroscience part, is to explain it. I think beyond that, more importantly, is that this recognizes right out the gate that this is a treatable disease. There are methods that work. We can address substance use disorders and addiction when doing it effectively. People with addiction use substances or engage in behaviors that become compulsive and continue despite harmful consequences. And that's how we know something is off, right? There's negative things happening to the individual, but there's a continued use. And we'll talk about why that happens. Prevention and treatment efforts and approaches for addiction are generally as successful as those for other chronic diseases. And despite that, we don't see the same level of support, right? It's almost like as we work our way through healthcare, we see more stigma and less support when it comes to our physical health. We have ribbons, we have rallies, we have all types of resources and support and individuals that will care. And you talk about mental health, a little of that stigma starts to sneak in. You go, well, why do they need pills? Are they crazy? Why do they have to see a shrink? Whatever it might be. And then substance use gets the worst of it, right? Like, those are just criminals. These are bad people or bad choices. Why don't they just stop? We lose empathy as we kind of work through. So although it is a medical disease and we can treat it in the same way, in a lot of ways more effectively than others, it doesn't get that same level of support. All right, that is my intro and stall attempt for these bad drawings that are on the way. Is there a white screen up there now? All right, perfect. We'll test. Yellow smiley up there. Okay, good. Here we go. Okay. Oh my gosh, cooperate. So when we talk about addiction, we're dealing with the brain, and our brain is full of these neuropathways, which are really just kind of like these tree branch-like structures that go throughout. And there are trillions of these. There's more neuropathways in your brain than there are observable stars in the universe. It's so complex that even our brain forgets where it puts stuff. You'll be in a conversation with someone, you're like, what was the name of that actor or actress? And it can't come to your mind. You move on with your day, but your brain doesn't. It keeps checking branches nearby. And then sure enough, if you're like me, at like 3 a.m, it finds it, it runs to the front of the brain, wakes you up, hey, it was Scarlett Johansson or whatever it is, and then, great, thanks, I need that information like at 11 a.m. today, but you have it now. But just all that to say, it is incredibly vast. Addiction, the bulk of everything we're gonna talk about, takes place right here, and that's what I'm gonna zoom in on. So it's essentially the end of one neuron and the beginning of another. We get this little space called the synaptic cleft. So you might have heard of a synapse firing or a synapse signal. What that happens between where one almost touches another. And in here on one side, we have what's called the axon side, and all you need to know is that it sends things. And then on the other side, we have the dendrite, and all you need to know is that it receives. And then we have right here the reuptake. Think of this as like the recycling center for the brain. So we've got a side that sends, a side that receives, and a side that recycles the things being sent and received so that they can be distributed later. Does anyone know the name for things being transmitted in a neuron? That's a hint. Transmitted in a neuron. What kind? Neurotransmitters, yeah. Neurotransmitters are what gets sent. There are several, but there's just 3 we're going to talk about today. The big one will be dopamine. It helps with pleasure and reward. You might have heard of serotonin. This helps with mood. And then norepinephrine, which I'm not even going to attempt to spell, helps with focus and control. So let's start with serotonin. So the average person's got a certain amount of serotonin that those axons send out. They go into those dendrites and then pulled around to get recycled and reused later. Some individuals, for whatever reason, are born, there's less serotonin that's being produced and distributed. And serotonin is something that helps us with our mood. What diagnosis do you think might be common for someone who just doesn't have a lot of serotonin being produced? Depression, right? This is kind of the leading theory behind depression is these low levels of serotonin. Most common medication class prescribed is a class called SSRIs, which this is gonna sound like a mouthful, but we'll break it down. It stands for specific serotonin reuptake inhibitor. Okay, reuptake, that's the recycling center. Inhibit means to block, and that's all they do. They prevent serotonin from going into the recycling center. So in this person, even though they don't have much serotonin, when it goes to get recycled, it can't, because the medications have essentially blocked that door. So it goes back out and it keeps sending more signals. So SSRIs don't make you happy. They don't produce serotonin. You still need therapy or exercise, sleep, proper diet, things to produce it. But the idea is that they'll make it last longer. You'll get more bang for your buck out of it. These will block it from entering the recycling center, and it can keep your mood kind of elevated for longer. Make sense? Absolutely. Everyone knows how antidepressants work now, or at least the theory behind it. Norepinephrine, we can have the same kind of effect. We could have low levels, we could have neurotypical levels, or we could have high. And low, just like for serotonin was depression, low levels of norepinephrine is often associated with ADHD. And ADHD, it's difficulty focusing, impulse control, all these other hyperactivity, these other symptoms. And one of the most common classes of medications for this is amphetamines like Vyvanse, Ritalin, Adderall, things like that. Like that's very counterintuitive, right? So we have like an individual, they can't sit still, they can't focus, they're having trouble concentrating. Let's give them speed every morning for breakfast, essentially. That's what we do. But what happens is it can boost norepinephrine levels up to a more neurotypical level, and then that individual is better able to exhibit, control, focus, things like that. When the problem comes in for a lot of times, like young adults, college-age students see these medications, they're like, oh, it's like a study drug. Like, it's gonna help me focus, it's gonna help me process, but you're already starting at a neurotypical level. You're not running at a deficit, so it boosts you into high levels of norepinephrine. And really extended misuse or repeated exposure to that can cause things like schizophrenia, amphetamine-induced psychosis, a variety of like really, really negative symptoms. There's a movie, Requiem for a Dream, and in that movie, the main character's mother's taking these diet pills that were amphetamines at the time when you could do them in like mail order, basically, before it became, I think, a controlled substance, and they understood the true dangers of it because it also suppresses your appetite. Throughout the movie, she's taking more and more. She starts to have these audio and visual hallucinations. The TV's like chasing her around. People are coming out. The fridge is trying to eat her, all these weird things. And if you don't know the background, you're like, this movie's just gone off the rails entirely. But they actually nailed a lot of the symptoms of what happens to someone who continues to misuse these medications when they don't need it and why it's such a dangerous medication to misuse. All right, but on to dopamine. So dopamine's the big one. So one thing that virtually every single substance involved with substance use disorders has in common is that it releases dopamine. And a lot of times people use words like addiction and dependence interchangeably, but they're very different processes. So addiction takes place with the dopamine system by and large. So anything that releases dopamine has the potential for addiction. So our pleasure center or reward center, there's three big things that release dopamine naturally. Does anyone know what they are or have guesses? What does the brain find what does the brain give us a bunch of pleasure for doing? Three big things. What? Playing is a smaller one, but not one of the big ones. Eating. Yeah, intimacy. The third one we don't do as often as we should typically. Exercise, right? We tend to be like really good at 2 or 3 for the most part, like things that bring us pleasure. We've got eating, intimacy, sex, exercise, working out. These are things that naturally release a ton of dopamine. So what's important to note, these acts aren't pleasurable. When the brain knows that you're doing them, it gives you a bunch of dopamine, and that is what you experience as pleasure. So the brain is intentionally rewarding you when you engage in these behaviors. If you didn't get dopamine, you wouldn't enjoy them. You're not actually enjoying the workout or enjoying the intimacy. You're enjoying the dopamine, and the dopamine is coming because you're engaged in those things. It's like the brain's internal kind of dog treat when you sit, right, to reward you, essentially. So the brain's trying to keep you alive, right, and it's trying to make more of you. So if it can keep you healthy and keep you working out and get you reproducing, it can keep everything going. So there's a really strong reward system built in around essentially survival, keeping you alive by rewarding you for doing things that are critical to your survival. Drugs essentially cheat that system. When you get high, and this includes, again, caffeine, nicotine, THC, we talk about, is marijuana addictive? Yes, it releases dopamine. Any drug that's pleasurable releases a flood of dopamine into the system. So this is normally reserved for when you've done a big workout or you've done extensive dating or something is going, you prepared a good meal and you're eating it. And instead you found something that's, all I have to do is snort this, sniff this, take this pill, whatever it might be, smoke this, drink this, and I just get to shortcut and I get to feel like 10 times better than I would even feel doing those things. It's cheap, it's readily available, whatever it might be, and it feels phenomenal. Because again, these transmitters give you pleasure. So you get a significant amount of pleasure. And I think that's important to note too, because I think a lot of poorly done education around prevention is, just you're going to use and all your teeth are going to fall out and you're just have this horrible time. And it's usually not people's early experience. It's usually very positive. They feel really good. They've got all these positive chemicals and everything that are going on. Typically, the police don't just swoop in the first time you get drunk or use, so it's not like you're facing immediate consequences. So odds are there's a lot of individuals who are like, well, I'm just going to do this again. Like, I found this shortcut. It feels really good. I'm going to keep doing it. I'm going to keep going back. So they do. So they use again and again and again. But the brain is trying to reach homeostasis. It wants balance, and it knows that something is off, essentially. There's way more dopamine being released than should be released, so the brain tries to adjust for it. So what it does is it turns off some of the axons to try to balance for it. So now the next time the individual gets high, not all their axons work, so they don't get as high as they did before. What might that person do? Use more, right? So they use more. Maybe they use what we call like a harder drug, which is essentially just going to release more dopamine, or maybe they're going to mix and match drugs, but it now takes more. And then you get into this back and forth where you're using more, axons are shutting down. So here, you would have to use like 4 times as much as when you first started. And what's important to note, it's not to get 4 times as high. It's to get just as high as you did the very first time you started. So in individuals, their use is escalating. They're not getting more and more high or having greater and greater pleasure. They're usually just trying to get back to that kind of level they used to get at the beginning. It just takes significantly more substances to get there now. This is tolerance, a term that a lot of us are familiar with. Weirdly, tolerance, especially with like drinking, a lot of times is associated with bragging rights, which doesn't make a ton of sense to me, because you're essentially saying like, if you're like, I can handle my liquor, I'm a heavy drinker, you're essentially saying like, my axons don't work and my brain doesn't function properly, so it takes me significantly more to get intoxicated than it used to. So if it takes more drinking to get drunk or more of a drug to get high, this is the reason why axons are not working as the way they used to. And then like the lightweight, right? Like, oh, they can't handle their liquor, they get drunk so easy, they get high so easy, is essentially saying like your brain functions exactly like it's supposed to, and we're gonna try to make you feel bad about that for some reason. So you get into this back and forth where you see use escalate. Second stage is the dendrites start to turn off. And as those turn off, it doesn't matter how much dopamine is in the system, because if there's no essentially like keyhole for it to go into, there's no signal for it to actually deliver, because these kind of holes of where it delivers signals are getting closed off, how good or how high that individual can feel, it's like the ceiling is slowly coming down. So how high you're able to get gets less and less and less. And a lot of times that's met with like, okay, so I must not be using enough. And you ramp up use, and this process can happen really, really fast. So now in this state, if this individual doesn't have their substances, it's a pretty miserable state. No dopamine. Even if they, exercise, work out, do what they're supposed to do, they get like, bloop, like one little tiny bit of dopamine. They lose the ability to not only produce pleasure, but process pleasure. Only 2 big words left. This is one of them. Anhedonia is this phase, and it's an inability to feel pleasure. And I think inability is key. Not unwillingness. They're not choosing to be ungrateful. They're not choosing to have a bad attitude. How could you not be grateful after XYZ or this night's dinner or your daughter's whatever the situation might be? It's not a conscious choice to be ungrateful or miserable. Their brain has lost the ability to feel pleasure even when it's present. It can't make it, and even if it finds a way to make it, it can't feel it. It's a very, very miserable state to be in, because you've lost the ability to produce and process pleasure even when it's supposed to be there. And this is something that gets stigmatized a lot, right? Like, why aren't you more grateful? Why aren't you more happy? Why aren't you this? Not realizing like the brain can't do that yet. Early recovery a lot of times is going to feel way worse before it feels better, because drugs were the only thing that kind of kept up with it, with that imbalance. It was the biggest producer of dopamine that was there. All right, now the drawings get like really bad.
Pretty good so far.
I appreciate the lie. Oh, that chin. And neck. Oh, man. All right, well. I say it every time. Like, I get worse, not better, the more I do this, which is sad. All right, that's allegedly a person. All right, so up here at the front, we've got the prefrontal cortex. It is our logic center, decision maker, choices, morals, values, kind of all that stuff comes out of there. Our limbic system, amygdala, all of that, we'll kind of generalize it to the midbrain. It's got our fight or flight. I only drew in half a prefrontal cortex because I work a lot with youth, and I try to remind people that until you hit the age of 25, you actually don't have, the average person doesn't even have a fully developed prefrontal cortex. So just remembering, like addiction aside, if you're dealing with an adolescent, they have half a prefrontal cortex. I try to get people to repeat that as like a mantra. Because if you're getting frustrated with a kid for not thinking as rationally as you, not weighing the pros and cons, not thinking through the consequences of their actions, you're getting mad at them for not doing something they can't do yet, right? I think it's the phrase, like, you'll understand when you're older. I think we misinterpret that, like, oh, you're gonna go through life experiences that change your perspective. In reality, it's no, you get a brain that can understand things it can't understand until it just fully develops. And then we look back, right, at like our dating choices and our outfits and our haircuts, and we're like, that was pretty irrational. I don't feel great about a lot of the things I did because you now are viewing it with a different brain. But at the time, you were adamant that was the way to do it. So these systems don't really cooperate is a good way to think of it. Your brain's usually either using your prefrontal cortex or your midbrain. So you're driving in traffic, someone cuts you off. Stress and danger is what triggers our fight or flight. So there's this moment when you get cut off that you might get hit by a car. So your brain goes into fight or flight. But then, you don't get hit, but you're stuck in fight or flight, right? So that's where maybe like some choice words come out, some honking, a finger of your choosing shoots up into the air, whatever happens, that's your fight or flight system. I need to fight something, right? I'm stuck in there. And then your prefrontal cortex takes over, right? Like I just need to get where I'm going. I don't need to like wreck my car. All those logical decisions come back. But stress and the perception of danger is what originally triggers that system, and the prefrontal cortex is what helps us think logically. So by and large, it's using our heart rate a lot of times. So if our heart rate's going way up, we're more likely to enter fight or flight. But stress is kind of the big driver of that, and stress definitely impacts heart rate, heart health, and things like that. So individuals with addiction, when this process of the axons and dendrites shutting off and this dopamine deficiency starts, for whatever reason, in some people and not in others, the brain treats it like a threat to their life. And it cuts off their prefrontal cortex, like actually limits electrical activity, blood flow, which limits the amount of oxygen that gets to that part of the brain. And it pursues getting more substances and getting more dopamine using the fight or flight system. So this individual, when they desperately need the ability to weigh the pros and cons of their actions, to use, sound thinking, consequential judgment, all of these things, that part of their brain literally gets turned off. And they get the same part of their brain you get in like a road rage moment to be able to make that decision. And it's convinced that dopamine is the only way to stay alive. So they're gonna pursue getting more. Other individuals keep full access to their prefrontal cortex when this happens. And that's one of the biggest reasons it is so hard to empathize with someone with a substance use disorder. Two people go out drinking, both of them in their heart of hearts and in their prefrontal cortex just wanna have one drink. They have a budget, they've got a drive, they've got all the motivation in the world. One has their drink, they keep their prefrontal cortex, they're able to remember all of those things. The other person, they get that flood of dopamine, all those same intentions were there, and then that part just gets turned off. So it's not that they don't care, or it's not that they don't want to care, they just can't access it anymore. And they feel like if I don't keep drinking, I'm essentially going to die, and I've got to continue drinking or I will die. And the other person's like, just think about it. Just think about the consequences of your actions. Like, just make better choices, not realizing they've got access to the part of their brain that this person no longer has access to. You can't see it, right? We see it in the behavior, but we can't see those actions. And for a lot of people, this makes a lot of sense. So like, okay, I remember that. It's like, I didn't want to make these decisions I was making. I didn't want to act that way. I would, have these moments of clarity and I would get my prefrontal cortex back, but then you're hit with all the guilt and remorse of what you just did and said. And sometimes that's enough stress to put you back in fight or flight, which is where you're gonna use again. This is why most relapses happen around stressful events. A lot of people are like, why would you relapse on the wedding or this day or that day? Not realizing that the stress of trying to be sober, or the stress of not making a mistake is enough to put the person into fight or flight. And then when they're in that state, they're going to seek kind of continuing to use. So people who've dealt with addiction can relate to that. But if you haven't dealt with addiction as a disease, you have experienced this phenomenon. And what it's called is hypofrontality. Last big word. Inability to use your prefrontal cortex. And again, inability, not that it's not that they don't want to make good choices, it's not that they don't care, it's not any of this. They cannot access and correctly use the part of their brain responsible for logical decisions, thinking things through, all of the things that they truly want. It gets pulled away. So this same state happens to people who don't have the disease of addiction, and everyone listening, I'm sure, has had this state as well. And the same phenomenon happens when you get really, really angry. Because when we get really, really angry, we're about as deep into fight or flight as we can get. And we obviously don't have to share, but think about the decisions we make when we are extremely angry. Think about the things we say, right? We pick fights with drywall, we slam doors, we tell loved ones like really hurtful things, we break important things. And I don't think anyone would say that how they acted or what they did when they were really angry represents who they really are or what their values truly are or who they are as a person. I certainly don't think anyone would want to have to share what they've done or have a spotlight shown on what they did, or if a camera was recording when they were at their angriest, it would be probably their worst nightmare video to get out. But that state is what addiction is like. So imagine being stuck in that state for weeks, months, years, right? And everyone's judging you for it, and everyone's trying to shine a light on it, make you feel bad about it, and shame you for it, and try to get you to change through that way. Like, that's what trying to seek treatment a lot of times is like, is having to shine a light on that, and people acting like that's who you really are, when we know that how we act in those states isn't remotely like who we truly, truly are. And that state can happen to anyone. It happens again when we get angry. We don't typically have the same fight or flight threats that we used to, we're not really getting chased around by like saber-toothed tigers anymore. Our brain does a really bad job at distinguishing physical harm from emotional harm. So most of the time we're in fight or flight, it's because someone's hurt us emotionally, someone's hurt our feelings. They've said something that frustrates us. And our brain can't process that this emotional pain isn't actually physical, and we get frustrated when we go into fight or flight, even though there's actually no physical danger present. So it's a phenomenon that happens to everyone, but addiction, for whatever reason, gets triggered in some individuals and not in others. Again, we know there's genetic predispositions. Trauma is a big player because, again, what you respond to as a stressor is totally different than other individuals. You might be quicker to fight or flight in certain situations than other people. But again, none of them are a guarantee, and we don't know why some people have this happen and other people don't. But we know it's kind of the distinguishing factor between addiction and just use is when this kind of process between these two parts of the brain changes. This is also why you should never try to problem solve if you or the other person is angry. It can't be done. You don't have the part of your brain, or they don't have it. No spousal conflict has ever ended with someone yelling back, "You know what, you're right." It just doesn't happen, right? It's the next day, it's after, "I'm sorry, I thought about it." Like, it's when we calm down. Like, you just have to get your heart rate down. We have to get our prefrontal cortexes back. It's never gonna be resolved because the parts of the brain we need are long gone as soon as we get kind of upset. Everything make sense?
Absolutely.
All right, good. Let me switch back
bad drawings are done.
Where have you been for the last 20 years?
Best explanation I've ever heard.
Well, thank you, thank you. It has been a lot of crafting in the works. As promised, highly educational, poorly drawn. So some of the key terms we talked about. So that neuroflooding is just all that dopamine. That's how we get high. All drugs do that. Tolerance need more of the same to get the same effects. So again, they're not getting higher and higher. It's just taking more and more and more because those axons are turning off. Withdrawals, we don't have the dopamine we need. We feel terrible. They feel pretty miserable without the substances. And you get to the anhedonia state where you can't even feel the pleasure even if it's there. That hypofrontality to me is the most critical part to understand, an inability to use your prefrontal cortex. I didn't talk about this, but glutamate, another thing that gets released is a neurotransmitter, glutamate, and it's responsible for forming memories. So what happens when individuals get high is they get a bunch of glutamate and they get a bunch of dopamine at the same time. So what happens is they get these really positive memories of when they use drugs or when they drank. So the brain gets super biased towards thinking like it was a really good time and I had a lot of fun, because when the dopamine's present, the memories are stronger. And then when the dopamine's not present, they don't. So a lot of times they remember it as being way better than it was. A lot of treatment centers try to tell patients, don't glorify it and this and that, but they genuinely do a lot of times remember it as being much better than it was, because memories form stronger when you're under the influence in that way. Then you get cravings. Cravings are normal. Our brain's like, hey, I just turned all this stuff off because you were gonna get dopamine every day, and now you're telling me you're not gonna get dopamine? So the brain's initial response is not, okay, great, we're on the road to recovery, let me turn everything back on. The brain's original response is, go get more of whatever you were doing. Like, I can't turn all this stuff back on. Like, you need to go get high, whatever it was you were doing. So cravings are very normal. But a lot of times, again, something that gets stigmatized. How could you want to use again after all it's done or after all this time? It's a very healthy brain that wants that back. And then this is where you're also at risk for kind of cross addiction, right? Like a different source of dopamine. So we see people in early recovery jump into like heavy gambling, sexual addictions, all types of other behaviors that come up, and the brain won't essentially heal. It'll just learn, okay, this is my new source of dopamine. Like 12-Step learned that early on, programs like AA and NA, because they realized like people keep jumping into relationships, essentially having a ton of intimate relationships and relapsing. So they started making it the norm, like, okay, stay out of a relationship for a year. Don't get a sponsor that's a gender you would have sex with, whatever it might be, like trying to prevent that. And they saw people were more successful. They didn't realize it at the time, but the neuroscience supported that. If you just used essentially intimacy as a source of dopamine, the brain wouldn't turn these things back on. It would just say, okay, we're just gonna use intimacy now, or we're gonna use gambling now, or we're gonna use shopping now. And that's the danger with, okay, well, I'll just smoke weed or I'll just drink. I won't use these hard drugs or whatever it might be. So a lot of times in early recovery, we see that. And from working in residential treatment, this is what you're always kind of up against. Patients are wanting to hoard food. Everyone's wanting to fall in love. People are trying to make a gambling event out of everything. And it's just, they're just trying to produce dopamine, and understanding that, okay, they're not trying to just break rules. They're not trying to, like, they're desperate for dopamine, and they're getting creative trying to find it. Healing. The brain does heal. This pleasure kind of pathway, one of the biggest studies found that really, really heavy long-term methamphetamine users, kind of their full dopamine response system at about 12 to 17, so a year to a year and a half, 12 to 17 months, it was restored basically back to normal functioning. Now, it doesn't take that long for any progress. That was for kind of full healing. A lot of early work and progress happens very, very early on and really quick. But, different drugs do other things that can cause different damages, right? If an individual had an overdose, so the brain went without oxygen for a certain amount of time, or some of the other side effects, that's where it gets really, really case by case. Like, there could be things that don't return. There could be permanent IQ damage. There could be permanent health damage. But the dopamine system we talked about today shows a phenomenal ability in just about everyone to fully restore and heal itself back to normal, to where they get normal dopamine responses, they can process it, all of that anhedonia goes away, And again, the more you can keep them from just substituting another addiction, the better the odds are that that process will happen successfully and faster, as opposed to just switch to a new source of dopamine. This is called temporal discounting, and it's a phenomenon I think is really important to talk about when people are addressing individuals with substance use. But basically what they did is they measured how much our brain responds to rewards and aversions, so good things, bad things. So think winning the lottery, getting hit by a car, crude but relevant examples. And then they had people think about those things happening to them or to other people, happening now or happening in the future. The white line is us winning the lottery or getting hit by a car now. Our prefrontal cortex lights up, super engaged. I would love to win the lottery. I would also love to not be harmed. The blue and gray lines are other people having those things happen to them now or in the future. Our brain doesn't really care, unfortunately, if you win the lottery or if you get hit by a car. It's very interested in those things happening or not happening to us, much less concerned if they happen to other people. So kind of a selfish creature. What was interesting, though, is the green line. So this is us in the future. And what you see is the green line actually follows a closer activity path to a stranger than it does to us. And what we learned is that our brain essentially treats future us as a stranger. It doesn't necessarily think of it as us. And the further we go out in time, the less we associate those things with actually being us or relevant or important. So this idea of like telling someone, if you keep using down the road, you won't be able to go to college, or down the road, this will happen. You're essentially saying, like, if you keep having the time of your life, someone else is going to go to jail. Someone else is going to have consequences. And a lot of our interventions are kind of targeted at these like long-term benefits and the long-term consequences. Our brain does not, it wants to know, like, what's in it for me right now? Like, what is the immediate advantage or disadvantage of what's going on? So really trying to tie things to long-term rewards and consequences is not a good motivator. This is why more people will buy lottery tickets than will invest in their retirement, right? Like, one is a guarantee, one is not gonna happen, let's be honest. But the lottery feels immediate, even though it's not gonna happen, whereas retirement feels so far away, your brain's like, someone else gets that money. It's the same reason we won't walk into traffic now, but we might smoke, not exercise the way we do, not do things that we know objectively will keep us alive longer, because our brain, again, is like, that's someone else that loses those years off their life. That's not actually me. So we'll do things that will hurt us long-term because our brain essentially thinks of that as being someone else. So again, all of this was targeted at hopefully increasing empathy. And this is kind of my closing remarks on why empathy is important. So it turns out empathy is the top predictor in how effective you will be at treating substance use disorders, is whether or not the clinician or the individual has the therapeutic skill of empathy. One study showed 25 to 100% variance in successful outcomes correlated with empathic listening. So the counselors who scored low in empathic listening, only 25% of their patients completed this program, and the counselors who were high in empathic listening had a 100% completion rate. Every single one of their patients made it through the program successfully. And it's not just how they do in the program, it's long-term. They've found that the more empathic and client-centered the counselor style, the less risk of relapse. There was a strong correlation to sobriety 2 years post-treatment based on their listening skills. So the strongest correlate and predictor about whether or not they were gonna be sober 2 years later was how empathic the counselor was when they had treatment. Another study showed that they would have 1/6 the relapse rates at a 2-year follow-up from patients who worked with highly skilled empathic listening clinicians versus those that didn't. So again, very significant, even up to 2 years after. It's a better predictor to use empathy to predict a client's sobriety than the client characteristics or the treatment methods used. So they try like the level of education of the counselor, CBT, this, that. We did this whole study, like Project Match, trying to figure out, okay, does 12-step facilitation or motivational enhancement, CBT, like what's the best? Empathic counselors screw up every study, because essentially, like, if they're empathic counselors, every theory works. And if they're non-empathic, none of them work. So it really came down to, like, if you have this skill, almost everything will work for you. But if you don't have this skill, everything's gonna seem like it's the theory. And that's a lot of times why we've blamed the patient, right? Oh, they're too resistant. They don't want it yet. They're not ready for it, whatever it might be, not necessarily recognizing like, oh, maybe if we were more empathic, like we could get them engaged and have a better outcome. This one's scary. Clients treated by counselors low in empathy tend to have worse outcomes than having received no treatment at all. So they actually did worse than the control group. They actually relapsed at a higher rate getting treatment than those who got no treatment if that treatment was done with poorly skilled counselors or low empathic counselors. A study by Val demonstrated a relapse rate 5 times higher by low-skilled clinicians. So it kind of brings you back to the planes, right? So like, it's not just unhelpful, but it is actively harmful to try to work with people as a clinician if you don't have that empathy in place. That's the end of my slides. Wow. Thank you.
Amazing presentation. I'm so glad that I got to be in the audience and take notes because this is my dream. I'm taking all this information and I'm here in the crowd. I mean, a lot of wows and a lot of just, I think I heard one comment here. I wish I'd heard this several years back, or I needed to hear this like 10 years ago. So I have questions. If we can borrow your time for just a little bit more.
Please.
So just kicking off on empathy, and I'll be asking a couple questions while those online or anyone here in person. If you have questions here, we definitely want to give space for that. But this empathy and the idea that it's better to have no therapist than one that doesn't have empathy. Because if they're walking in that room and they're showing like this tough approach and they're not understanding what they're going through, that individual's more likely to go and relapse than if they just had no one in the room in there.
And a lot of our interventions were intentionally designed backwards, right? You think of like the Scared Straight program, right? So we're talking about an adolescent who already has limited prefrontal cortex, and we know that the worst thing to do is to put them in fight or flight. And we take them into a prison, and we have a bunch of adult inmates scream at them. Like, what part of the brain do we think they're using? Like, do we think that they're getting into their prefrontal cortex, or they're immediately in fight or flight? So a lot of it's been miscalculated, and it's been about trying to shame people and treat them as though they're criminals, which just makes the issue so much worse as opposed to actually making it something that is treatable.
So my question is, you have family members, you have relatives who are saying, well, we're frustrated.
Yeah.
I'm about to lose my job.
Yeah.
You know, I can't sustain this. I can't support this. And so that frustration comes out. What do you tell a family member who's trying everything they can, but this is the go-to, this is default?
Yeah, well, I think first is normalizing it, right? So we'll talk with families, and a lot of times their fear is after that, like, did I make it worse? What, was I not empathic? Did I make it worse? And again, these are counselors. You're not their counselor. You're their family member, and it's very important that you understand you can't treat your family member. You've got to find a clinician or a treatment program that can. And it's hard, right? It's easier said than done because the symptoms of addiction are so abrasive and antisocial. But I think it does help family members to remember, okay, these are symptoms of the disease, not choices, not the person. These are symptoms. It just happens that these symptoms can involve manipulation, lying, these repeated issues, as opposed to other medical conditions like they become isolated, sad, whatever it might be, and it's easier to be more attentive to those symptoms as opposed to the ones associated with addiction. Yeah.
And there's a moment where you were talking about tolerance, and just the idea that as you take this drug long enough, was it the axons?
Yeah.
They begin to close off, and then you have to take more of the drug. So tell us a little bit about, in your experience, what happens to the individual that may have been off of drugs or off of alcohol for a long time.
Yeah.
And then they jump back in and say, wow, well, I was at this level, so I guess I need to start back there to get that same high.
That's where a lot of overdose risk is. So, a lot of harm reduction education is if someone's been in treatment or, abstinent from substances for a long enough time, those axons start to turn back on. And that exact thought enters their mind, right? I'm going to use where I left off, but they have way more axons than they did the last time. So what worked for them, at kind of the height of their use versus after this stuff is restored is going to get a completely different response out of the brain. So a lot of this is really good education for patients on, hey, like if you're going to use, you need to use significantly less, and here's why. I think a lot of people are hesitant to give that type of education because they feel like it's enabling or encouraging them, but I think it's just being more realistic. Like, hey, if this happens, you really do need to know this, and here's why it could cause an overdose.
And I'm going to ask a few more questions
Please.
here as we prep. If we can get a volunteer to help out with the microphone, and we'll move that around in case someone has a question here in the crowd. You mentioned harm reduction, and that's a phrase that we hear a lot. And tell us more about what that actually looks like, and how do families interpret that in their own homes?
So harm reduction we use all the time, every day. Like when you drive somewhere, your car has airbags and it has seatbelts in it. These are not things that prevent car crashes from happening. They make them not fatal when they do happen. And we accept those things everywhere. Fire extinguishers, seatbelts, again, as an example. So for substance use disorders, it can look like naloxone for overdoses, life-saving medications, teaching people, if you're going to relapse, here's how to relapse safely, or resources that you can use. Again, it's not stopping the use, but it's preventing it from being potentially fatal when it happens. For whatever reason, it gets really stigmatized with substance use, but no one's going to go, cut the seatbelts out of their car saying, well, this is just going to encourage more car crashes, so we need to take all these airbags out right now. But there's a push to do that with some of the harm reduction with substance use. I think it's just misunderstanding that this is a practice we use everywhere.
And when you say practice, it's not the only practice, but you use that in combination with other practices.
Yeah.
So how do you?
Yeah, ideally, you're able to do treatment alongside it. But I think understanding that relapse is a very normal part of recovery, not just for addiction, but for any medical condition or disease. Again, like if you treated someone for depression, you would never expect that they're never going to experience sadness again, or that an anxious person will never feel anxiety again. Asthmatics have repeated asthma attacks. People with hypertension have continued issues. Those are considered relapses. We don't stigmatize them. We say, okay, we need to address the treatment plan. We need to address it. Same thing with substance use. And actually, substance use relapse rates are typically lower than we see with things like asthma and hypertension, but we stigmatize it as though it should never happen.
And as we identify questions in the crowd, I'll ask one more question here, and then we'll get started with questions here from the crowd. You talked about adolescents developing the ability to make decisions for themselves, and we've heard it before referenced with other speakers about the age when insurance rates drop, about 25, which sounds like that's exactly for that reason. But what happens when you have a parent or a spouse and they're well over 25 and the family member feels frustrated because they're thinking, you should be at that point. You should be able to make these decisions. How do you work with a family that's seeing that?
Yeah, I think that this type of education is helpful, right? Like the most fully developed brain under stress can't use its prefrontal cortex. And a lot, we can have the most sound, rational adult, but if you put them under enough stress or in a stressful environment, you see very similar decisions to an adolescent or to someone developing substance use disorder. Kind of back to that anger example of how we act when we're angry, right? A lot of times we might even describe it as like I was acting like a child or throwing a temper tantrum or whatever it might be. And that's why, even though that part of our brain is developed, we can very quickly lose access to it and understanding that's what's happening when we get stressed. That's what's happening in addiction. It's an important process.
Well, Drew, speaking of stress, we are going to go ahead and put stress on you by taking live questions here from the audience. We have no idea what questions are going to come up.
Ready for it.
But Drew is ready.
So since I got the mic, I'm asking the first one.
Let's go.
So I've always heard that, you take a really good person and put them in a stressful, bad situation. Don't make a bad situation. Don't make a bad decision, which is what you just described.
Absolutely.
Okay?
Yeah.
So in my history of what I've dealt with, what you just said tonight, I've never heard this presented this way. I've never seen those incredible drawings the way you did them. And I am going to walk out of here with a massive amount of education in the last 45 minutes that had I had that a few years back,
right,
I'd have been really smarter. And my question is just a quick where all this came from, kind of how was, where did it come from, pieces and parts, and how prevalent is this? Obviously, this is what you're doing. You're trying to get this out
Right.
to everybody. Talk about that for just a minute.
Yeah, I mean, I think a lot of this is not new research. And I think that I get the same reaction that I've never heard it presented this way. This is the way that makes sense. And, I started bringing these types of materials even to like addiction conferences, like national ones. I'm like, okay, surely, my drawings are going to lose their magic there, right? And I get the same feedback there. So even within the field, this seems to be so unknown and underutilized, but it's not new research. I mean, I'm pulling on stuff that we've known for a really long time. So it's really just been a compilation of tremendous amounts of data and research that has been done. Some of those studies I cited were back to like the 70s, 80s. It's not new. It's just we've been so slow to apply it. And I think it's because it contradicts so much of the stigma that is just concreted in people's minds that, nope, these are just criminals. They're just bad people and don't want to hear anything the otherwise for whatever reason.
So as family members, you said empathy, more counseling than whatever the family member brings.
Yeah.
But also, like, you mentioned that part of the reason the prefrontal cortex turns off is it listens to your heart rate and your breath patterns. Yeah. Can you, as a family member, get them to calm down, breathe, slower? Can you guide them in that direction?
Yeah, you just look at them and yell, calm down, right?
That
we all love
works.
that, yeah. No.
I meant with empathy.
Yeah, no, absolutely. No, I think that just knowing that there may need to be slower paces, I think this education can be helpful to remember, okay, these are symptoms of the disease. This isn't how they actually feel towards me or their thinking, and keeping that front in mind can help that be an easier process. Because again, it's not easy when it's a loved one saying something hurtful or going through this. It makes sense, but then we emotionally feel very different about it. But I think the more people can try to keep this front and center and just not engaging and giving people space to catch their breath, calm down, let's come back and revisit this later. There's a famous marriage therapist, the Gottmans, and they have their couples wear heart rate monitors for that reason. You go into a certain target rate zone, they stop the session and wait because they know you're going to lose access to that part of the brain. You're not going to have a productive session. So they essentially won't do counseling until you're at like a safe resting heart rate, essentially. And they have tremendous success for that very reason.
Could you do that in the same situation? Like
You could. I mean, it's going to be up to the individual. Some people may not like, hey, put this, heart rate monitor on. But I think certainly allowing space, time, like we can tell when other people are escalated. And I think a lot of time we have the best intentions. We may try to push it too soon. And knowing that when you're stressed, you're not going to make the best decisions. So knowing that, when you're really frustrated, that's not a good time to go address the family member. Let me wait until things are neutral, as opposed to I've just gotten upset about something. I'm going to go tell them right now. You just won't make as effective decisions as you want to in that moment.
You talked about the brain, the ability to heal.
Yeah.
Is there ever a point where, it used to be people would say, oh, well, they've gone too far. They have wet brain, and it looks like dementia now. Is that possible? Can you?
Yeah,
will it heal after that?
That's where it's just so nuanced, right? It depends on what drugs did they use, what intensity, how old were they when they started, did they have overdoses? So there's certainly pathways that are going to lead to damage that won't undo itself. But as far as this process, it's shown an incredible ability to heal and recover. And then anything past that, it's a lot more kind of case by case, where we see people with significant damage. We see some people where it's completely negligible, and there's just kind of everything in between.
Drew, one more. Drew,
Yeah.
This is more of a comment, and you can just comment back. It nearly, hearing what I've just heard, and when you talk about the disease and how people don't recognize what it is and what they're going through and how to interact with them, it nearly makes you angry. Because if one of your family members gets cancer and they're frustrated and they're taking medicine and they're tired and they're irritated and agitated, you put up with it. You deal with it. Oh my God, they have cancer, this, that, and the other. My brain's telling me it's a disease. They're sick.
Yeah.
It's the same thing.
Yes.
But yet we get mad. I've done it personally because how could you do this? That's blowing my mind.
Yeah, to me, the illusion of choice. That choice is the big word to me that I think differentiates why we handle some things one way versus another. You know, they didn't have a choice in their cancer diagnosis. They didn't have a choice with, you know, diabetes, but they had a choice. They could have stopped using at any point. They could stop using today. And I think that illusion of they're just making bad choices leads to us to treat it completely differently, to view other people as they're victims of a true disease, and these are just a series of bad choices. And it really is, it was Dr. McCauley said, like, this is a disease of choice. I mean, that's exactly what it impacts and infects, is that ability. And I think when people truly understand that, they're like, oh, it just presents very differently. But the same way, yeah, you would never go around a hospital, you know, yelling at people, you know, sleep on the floor till you get better, or we're going to kick you out if you don't start acting like you want it, or, you know, they're just resistant. They don't want it yet, you know, kind of thing. Like, we're much more compassionate, much more caring, you know, willing to change up our treatment plans to try to better meet the patient's needs.
Drew, as we wrap up the time here, suppose there's someone in the audience or someone watching the video later on, and they're thinking of their family member, and they're thinking about everything that's been shared here, the amount of empathy that they want to demonstrate to the family member, the help that they need to get to them. Where do they turn to? Where would you guide that family member that says, where do I go now to help my family member or even help myself?
Yeah, I mean, certainly we can, you know, as a part of this Project Empathy Initiative, we work with families, agencies, schools, individuals. We're willing to provide workshops on this type of thing to help individuals really unpack it and weave it into the systems wherever they happen to work or whatever that environment may be. But I think really understanding that empathy is really understanding that person's story and really making an effort to understand what life is like for them, and to really just, okay, I want to, even if I don't agree with it, I'm just going to make every effort to understand